Hello and welcome to this presentation. In this presentation, we'll be looking at pressure ulcers. Okay, welcome. So these are pressure injuries, currently referred as pressure injuries, and these are localized damage to the skin or the underlying soft tissue, or both the skin and the underlying soft tissue. It usually occurs over bony prominence, most commonly the sacrum, ischial tuberosities, greater truncatus, heel, the malleolus, and the elbows. It normally results from intense or prolonged pressure or pressure in combination with shear, the microclimate, nutrition, perfusion, comorbidities, and tissue condition can affect the tolerance of soft tissue for pressure and shear, and thus resulting into pressure injuries. Pressure injuries can also be caused by a medical device, that will be when used or when applied on a patient. Pressure injuries are categorized by the amount of tissue present. So that brings about the staging of the pressure ulcers. Pressure injuries were formerly referred to as pressure ulcers, also called decubitus ulcers, pressure sores, or bed sores. Pathophysiology. We're saying that impaired skin capillary pressure results in local or tissue anoxia, the absence of oxygen. So that absence of oxygen leads to edema and multiple capillary thrombosis. An inflammatory reaction normally results in the acceleration and necrosis of ischemic cells. The causes of pressure ulcers is saying it may result from local tissue compression, okay, and we have the commonest areas where that can happen. We have it's also caused by the shearing force and the medical devices that we normally use when we are handling the patients. So the commonest area for the pressure injuries include the inner knees, the heels, you can see the hip or the lower back and buttocks, the elbow, the shoulder, and back of the head and ears. What are the risk factors for pressure injuries? We say that it could be associated with poor nutrition or decreased lean body mass. Some of the pressure injuries have been associated with diabetes mellitus, decreased mobility, immobility, or paralysis. Patients with cardiac disorders, advanced age, incontinence, obesity, edema, anemia, hypoxemia, poor hygiene, exposure to chemicals, use of corticosteroids, impaired awareness, decreased sensation, increased metabolic demands, increased moist or dryness, use of medical devices, prolonged procedures, and smoking. All of them have been associated with pressure injuries. What of the incidence? Is saying that pressure injuries affect up to 15% of hospitalized patients and 10 to 35 patients in long-term care facilities. So pressure injuries are more common in older adults. Most pressure injuries occur in patients older than age 70. These are the elderly. For hospitalized patients, prevalence ranges from 3.5 to 69, with increased risk for patients in critical care units. And the prevalence is mostly 41%. There is an estimated 1 million pressure injuries that occur each year in developed nations such as USA. Complications. We're saying that we normally have secondary bacterial infection, okay, and growth of resistant, possible growth of resistant microorganisms. Septic shock can arise. We also have sinus tracts, gangrene, cellulitis, squamous cell carcinoma, and Magellain ulcer. Assessments, starting with the history. From the history of the patient normally reports or presents with one or more risk factors. Okay, and physical findings, which are normally arrived at through inspection, palpation, percussion, and auscultation. We have shiny erythematous superficial lesion in early phases, or possible necrosis and ulceration with deeper erosions and ulcerations. We have malodorous purulent discharge, and this one normally suggests that there is a possibility of secondary bacterial infection. We also have black eschar around and over the lesion. Go to the diagnostic test results, starting with laboratory. We are saying that we have wound culture and sensitivity testing of the exudate identified so that we can know the infecting organism. We also have total serum protein is decreased. White blood cells count and differential may be elevated if the fever is present. The ESR, erythrocyte sedimentation rate test, may show elevated result if osteomyelitis is present. Albumin level test or pre-albumin test levels may be low if malnutrition is present. When you look at the other diagnosis, that diagnosis is typically made from a wound assessment. Treatment. Treatment, we have the general treatment, diet treatment, activity treatment, medication treatment, and lastly, surgical intervention. Starting with the general treatment, we have measures to prevent this pressure injuries. Okay, so we have a use of a risk assessment scale such as the Braden scale to identify action that can modify the risk of pressure injury formation. We also have relieve pressure on the affected area so that you turn the patient frequently. We normally say turn the patient every 2 hours, okay, to prevent pressure injuries. Offload the heels. That's we need to lift the heels of the bed to relieve the pressure. Okay. Yes. Ensure meticulous or careful skin care so that you cleanse the skin properly after the episode of incontinence. Okay, and use a pH balanced skin cleanser and a moisturizer daily. You also need to use specialized pressure reducing surfaces such as pads and mattresses to decrease pressure. You place a polyethylene dressing on the sacrum. Use of the VTE, venous thromboembolism prophylaxis, if the patient is hospitalized. Then you need to do a consultation with wound care specialist, nurse, or whoever the healthcare provider is. You also have control of incontinence, and through perineal care can also help to control pressure injuries. Okay, guys, I have a question here. You're developing a plan of care for a patient who is at risk of a pressure injury development. The patient is 73 years old and weighs 50 kilograms. The patient is confused and has a right and left leg contractures. In addition, the patient has urinary tract infection and is incontinent of urine. The patient is on aspiration precaution and is ordered honey thick liquid diet with the pure foods. Select all the nursing intervention you'll include in the patient's plan of care to prevent a pressure injury. So number A, they're saying that when feeding the patient, keep the head of the bed elevated at 45 and avoid elevating the foot of the bed without prevent a pressure injury. B, apply a barrier cream as needed to the skin daily. Turn the patient every 4 hours. Should it be 4 hours or 2 hours? Yes. So that one can be automatic elimination, okay? Should be at least 2 hours. Keep linen and gown dry and wrinkle free. Yeah, that's okay. We can keep that for consideration. And use a wedge pillow for the right and left legs daily. Great, kept also for consideration. So, ladies and gentlemen, A can be good for elevating the head, but it may not prevent pressure injuries. Okay, that's why it's not appropriate here. So here we need to apply the cream as needed to the skin daily. Okay, then we need to keep the linen and gown dry and wrinkle free, and use a wedge. Okay, a wedge pillow for the right and left legs daily. Okay. So option A is wrong because when the patient is sitting up, you want to prevent them from sliding down in the bed. Okay, this can cause friction and shear, which can lead to a pressure injuries. Raising the foot of the bed where the foot of the bed when the head of the bed is elevated will prevent the patient from sliding. Option C is wrong because you need to turn the patient every 2 hours, not 4 hours. Option E is beneficial for the leg contractures to prevent a pressure injury to the knees and ankles. Okay. So we look at diet, guys. So diet, you're saying that you normally do nutritional status assessment. We have balanced diet that's high in protein and iron. So vitamin C, unless it's contraindicated, is normally used to promote collagen synthesis and tensile strength. Vitamin A is used to promote epithelialization and fibroblast stimulation. Zinc is used to aid in protein synthesis. Copper is used to promote collagen production, cross-linking. Okay. Manganese is important because it promotes collagen and grout substance formation. Then you have adequate fluid intake to maintain hydration. And lastly, enteral or parenteral nutrition if necessary for that case. Okay? Yes. Activity. We're saying that activity should be as tolerated. Engage the patient in active and passive range of motion exercise, frequent turning and repositioning, and offloading to reduce the pressure. What about the medication as a type of treatment? Saying that you have enzymatic oil ointments to dissolve the necrotic tissue, antibiotics if indicated to treat bacterial infections. The physician will also prescribe topical antimicrobials such as silver sulfadiazine and triple antibiotic ointment for the non-healing pressure injuries. The physician will may also prescribe skeletal muscle relaxants such as baclofen to relieve spasticity if it's a contributing factor. Okay, spasms. Physician can also prescribe topical lidocaine for procedural pain relief. And lastly, a physician can also prescribe non-opioid or opioid analgesic to control pain. Okay? Great. What are the procedures that these patients are likely to be subjected in or the nurse is likely to be engaged in? In this case, we have wound care and application of appropriate dressings as ordered. And next we have negative pressure wound therapy for difficult wounds and non-surgical debridement. What about the surgical intervention? We have sharp debridement of necrotic tissue, direct closure, flap reconstruction, and skin grafting in severe cases. Nursing consideration. We're saying we need to perform skin assessments per shift as needed according to the facility protocol to identify the risk of pressure injury formation. Also use appropriate pressure reducing surfaces to minimize the risk of breakdown and to prevent further breakdown. Okay, we need to apply air foam or water mattresses overlays for the stage 1 and 2 pressure injuries. Use dynamic surfaces such as alternating air overlays and low air loss beds for stage 3 and 4 pressure injuries. Also turn and reposition the gland regularly and frequently unless contraindicated. Okay. Base the frequency of repositioning of the gland's tissue tolerance, skin condition, morbidity, medical condition, and treatment goals. Okay, you need to pad bony areas, use pillows for support, and offload pressure, such as the heels. You need to provide meticulous skin care. Frequently inspect the skin, especially high risk areas, for changes. Wash the skin with mild soap, rinse, and pat it dry with a soft towel. You implement standard precautions when performing skincare. We need to avoid massaging the reddened areas. Use lotions as appropriate to prevent drying. We will not want drying of the legs because this one is likely to result into pressure injuries. You need to ensure use of proper size and type of medical service device and check that the device is secure. Pad the skin as appropriate and follow the device manufacturer's recommendation for use and care. You need to position and reposition a medical device that may contribute to skin breakdown. Remove the device as soon as medically feasible. Give prescribed drugs, apply the topical agents as ordered, give systemic antibiotics based on the culture and sensitivity testing if bacterial infection is present. We need to perform wound care and apply a new dressing as ordered so that we note the appearance of the drainage on the dressing, including the amount and characteristics, elicit the aid of a wound, incontinence, the ostomy nurse to assist with wound care. You screen for and assess the patient's pain. You could use the OPQRS, the Socrates, okay? Treat the patient's pain as needed and ordered using non-pharmacological, pharmacological, or combination of the two. You anticipate medicating the patient with analgesic 30 minutes before performing wound care. I think that's very important. You closely monitor a patient who is prescribed opioid treatment and is identified as being at risk of uh, adverse outcomes. Reassess and respond to patients' pain by evaluating the response to treatment and progress towards pain management goals. Encourage adequate food and fluid intake. Offer high protein foods to promote tissue healing. Administer enteral feeding if needed. Elevate the head of the bed at least 30 degrees during feeding unless contraindicated. You need to perform passive range of motion exercise as appropriate and encourage active exercise if possible. Apply anti-embolism stockings or sequential compression stockings to prevent the VTE. Assist the patient with toileting. Provide skin care if the patient is incontinent. Lift rather than push or pull when moving the patient to avoid shearing. Okay, you lift the patient. Don't push, now pull. Prepare the patient and family for possible surgical debridement or skin grafting if possible. For any bedside procedure, anticipate patient positioning as well as medical equipment and supply that will be used. Take precaution to prevent pressure injuries by using, for example, foam wedges, headrests, or bean bags, positioning devices. Okay? Here are some of the range of motion exercises vis-a-vis the isometric exercises. Like the range of motion, we have the flexion, extension, hyperextension, extension, flexion, rotation, supination, pronation, circumduction, abduction, adduction. Then you have the isometric exercise, the contraction of muscles. I don't know which one is your favorite position, but you can be able to see all of them. Great. Monitoring. What are you supposed to monitor? Monitor the skin integrity and changes surrounding the skin color, texture, temperature, and sensation. Monitor pain level and effectiveness of interventions. Monitor wound appearance, including any changes to pressure stage, wound drainage, nutritional status, hydration, fluid balance, laboratory results, complication, response to treatment, and lastly, skin graft and donor site if possible, okay, in the case of surgical interventions. What are the associated nursing procedures? The nurse will be involved in air fluidized therapy bedside, agilite dressing application, alignment and pressure reducing device application, ambulation, okay. Nurse will also be involved in anti-embolism stocking application, endotracheal tube repositioning, hydrocolloid dressing application, hydrogel dressing application, low air loss therapy bedside use, the negative pressure wound therapy, nutritional assessment, pain management, parenteral nutrition, monitoring, and changing of the equipment, performance of passive range of motion exercise, perineal care, both for the female and male, pressure injury prevention, sequential compression therapy, wound assessment, irrigation, and specimen collection for that matter. What about the patient teaching and general? We're saying in general, you include the patient's family and caregiver in the teaching where appropriate and provide information according to the individual's communication and learning needs. Be sure to cover the disorder, the diagnostic testing and treatment, including preventive measures, use of overlays and pillows for positioning and reducing shearing forces. Need to avoid raising the head of the bed more than 30 degrees. Okay. Active and passive range of motion exercise. Cover the prescribed medications, including drug names, dosages, rationales for use, frequency for administration, possible adverse effects, and duration of therapy. Use the pain management plan and potential adverse effects of pain management treatment. Use of safe use, storage, disposal of opioids if prescribed, avoidance of skin damaging agents, daily skin measures, regular assessment of the skin under medical devices, okay? Wound care measures, including the dressing changes and the use of the topical agents. Debridement procedures such as mechanical or chemical methods, including the purpose, frequency, and method. Skin grafting surgery if required. Also teach about the signs and stages of healing as well as signs and symptoms indicating pressure injury progression. Teach about the importance of a well-balanced diet, high in protein and iron, including a discussion about appropriate food choices. Teach about importance of adequate fluid intake, signs and symptoms of infection or progression, including the need to notify the healthcare provider immediately. Teach about the measures to prevent future pressure injuries. Then lastly, teach about the importance of follow-up care to determine the effectiveness of the therapy and the condition of the pressure injuries. What about the discharge? You need to participate in the multidisciplinary team to coordinate the discharge planning efforts so that this team will include other nurses, social workers, care managers, physical therapists, occupational therapists, and wound care specialists, including the surgeons and the nutritionist. So here, you need to determine the appropriate post-hospital setting to which the client will be discharged. Is it at home, in a nursing home? Okay. Determine what the client's level of independence was before admission and evaluate how the current illness will affect the independence level. Ask the patient's and the family understanding of diagnosis, treatment, prognosis, follow-up, signs and symptoms for which to seek medical attention. You need to identify the patient's formal and informal supports that will help in recovery. Identify patients and family goals, preference, compression, concerns about discharge. You need to provide a list of the prescribed drugs, including each drug's dosage, prescribed schedule, adverse reaction to report to the surgeon. Also provide the patient plus the caregiver, okay, or family if required, with written information on the medication that the patient should take after the discharge. You need to assess the patient's and the family understanding of each prescribed medication, including the dosage, administration, expected results, duration, and possible adverse effects. You also need to assess the patient's ability to obtain medication. Identify the person responsible for obtaining this medication. Instruct the patient to provide the list of medication to the healthcare provider who will be caring for this patient after discharge, and to update this information so that no other drug is prescribed outside the list. Ensure that the patient and caregivers receive medical contact information. Provide information on home care services and continued wound care therapy if needed. You need to provide contact information for local support groups and services. Ensure that the patient or the caregiver receives a copy of the discharge instruction and that a copy is placed in the patient medical record for reference. Document the discharge planning evaluation in the patient's clinical record. Include who was involved in the discharge planning and teaching, the understanding of the teaching provided, and any other follow-up for follow-up teaching. Well, guys, thank you so much. We can have some questions now. Like here now, the nurse is reviewing the intraoperative record of a client. Which information will alert the nurse to the greatest possibility of a potential for skin breakdown? Well, guys, risk factors for pressure injuries, use of dorsal recumbent position, length of the surgery, provision of general anesthesia, transfer to the stretcher. Transfer to the stretcher, we need to be told if there was a shear, provision of general anesthesia. Guys, length of stay will be the one factor that will be indicating, okay, will be indicating the potential for skin breakdown, okay. So the length of stay is most important since the procedure lasted over 9 hours with the patient in the dorsal recumbent position. So this position is standard. So the dorsal recumbent position is standard, and the length of time will have given the client pressure on bony surfaces since there was not a position change. Okay. Having general anesthesia is a factor in the other potential surgery complication, and there is no evidence that transfer tests involved any shearing or friction. When assessing an elderly client, a nurse on the day shift notes redness in the sacral region. Close assessment reveals small breaks in the skin surface. The client says that this area is tender and must have lost the skin when a nursing assistant on the previous shift moved the patient. The client tells the nurse the nursing assistant on the last shift was rough. I asked the nursing assistant to look at my backside, but the nurse assistant said they were too busy. What should the nurse do first? Prepare an incidence report, record a disciplinary warning for the nursing assistant, document the findings, conduct the shift supervisor. Great, guys. The best answer is document the findings. Okay. The nurse must first document the assessment findings timely. Timely documentation helps ensure accuracy. The nurse should notify the shift supervisor after completing the documentation. Okay. The nurse must follow the chain of command. The nurse isn't a manager or a supervisor and may not have the authority to administer discipline. Although it might be appropriate for the nurse to make an incidence report, the nurse does not have adequate information yet to prepare a report. Okay. Next, the nurse is evaluating the client's risk for having pressure ulcers. Which is the best indicator of the risk for the clients developing a pressure ulcer? Nutritional status, circulatory status, mobility status, orientation status. Great, guys. The best one is mobility status. So the client's mobility status is the best indicator of risk for development of a pressure ulcer or pressure injury. Nutritional and circulatory status are other factors that can contribute to pressure source development, but immobility, even in the presence of adequate nutrition and circulation, lead to or can cause pressure ulcers. Disorientation can cause a client to neglect making needed positional changes, but the underlying factor will be immobility. Great. Which statement will be appropriate for a nurse documenting stage 1 found on a client who is immobilized? The client's skin is intact with non-blanchable redness of a localized area over bony prominence. The client's skin has a partial loss of the dermis, presenting as a shallow open ulcer with a red, pink wound bed. The client's skin is shiny, dry ulceration with bruising noted. The client's subcutaneous tissue is visible with blood blistered wound bed. Yes, guys, the correct answer is A. And you're saying that it's A because when you look at the stages of pressure ulcer or pressure injuries, we have stage 1 up to stage 4. So stage 1, we have non-blanching erythema. Okay, and this is normally in contact with the epidermis. Remember, you have the epidermis, dermis, subcutaneous tissue, and then the muscle fascia. So stage 1 works with the epidermis, okay, and blanchable erythema with intact epidermis, okay. Stage 2, we have partial thickness ulcer involving epidermis and the dermis, that is the skin, right? Stage 3, we have full thickness ulcer extending through the dermis to the subcutaneous tissue. And then lastly, stage 4, we have deep tissue destruction extending through fascia and may involve muscle, bone, and tendons. While performing an assessment on a patient who is immobile, you note a purplish black area on the patient's left heel. The skin is intact. On palpation, the site feels heavy and spongy. You suspect these may be deep tissue injuries. They are present as purplish or blackish areas over the skin is intact. The fatty tissue below is injured. Okay. Also may look like a black blistered area and may feel heavy or squish. Great. So clans who are immobilized in positions without regular positioning are more likely to develop pressure ulcers because of pressure on the skin for extended periods. And this is normally the definition of stage 1. While caring for a client who is immobile, a nurse documents this information. Turned client from side to back every 2 hours, skin intact, no redness noted, client up in chair 3 times a day, improved skin tagger noted. Which nursing diagnosis accurately reflects this information? Ladies and gentlemen, this is risk for impaired skin integrity related to immobility. So the patient will turn, the nurse will turn the patient every 2 hours. We look at the skin, assess the skin, encourage movement, okay? You're working with impaired, risk for impaired skin integrity related to immobility. So the information documented in the client's chart reflects the risk for impaired skin integrity because the client's skin is intact. The problem is only a potential one, not an actual one, which makes the nursing diagnosis of impaired integrity inappropriate. Okay. If if constipation were a problem, intervention will focus on diet and activity. And if body image were a problem, intervention will focus on the client feelings about himself and his or her desire. Okay. A nurse is caring for a client who has a limited mobility and requires a wheelchair. The nurse has a concern for circulation problems when which device is used. Thank you guys. Ring or donut. Okay. The nurse should not use the rings or donut because the client with any client because this equipment restrict circulation. Okay. Great. A client has a risk factor for skin breakdown due to incontinence. Which nursing actions or intervention for the client will help in decreasing the risk? Have the client scheduled for toileting every 2 hours? Yeah, this one you can keep for consideration. Cleanse the perineal area daily and after each incontinence can be kept for consideration. Encourage the client to decrease fluid intake or that one need to be eliminated. Apply adult briefs for the client and change every 8 hours. Changing 8 hours, that is too long, Maintaining, avoiding record to determine any patterns of incontinence. Ladies and gentlemen, we can have A, B, and E. Okay. The client should have scheduled toileting to prevent incontinence and needs perineal care daily and after every incontinent episode to maintain clean and dry skin. Okay. Thank you. The nurse is caring for a comatose older adult with stage 3 pressure ulcers over the 2 bony prominence. Which intervention should be added to the plan? Very good. Place the patient on a pressure redistribution bed, okay? So a pressure redistribution bed will allow for constant motion of the gland and prevent further breakdown. Lambstool may trap heat and exacerbate skin breakdown. Turning the patient should be at minimum every 2 hours, okay? Egg crate has not been proven to be effective to prevent development of pressure injuries. A physician has ordered a wet to damp dressing for an infected pressure ulcer. The nurse knows that the primary reason for this treatment is, ladies and gentlemen, wet, damp. The role of the wet damp is to promote the moist wound, to keep the wound moist, okay? And doing so keeps the wound bed moist, which helps in the growth of the granulation tissue, thus contribute to the healing, okay? A client is admitted with multiple pressure ulcers. When developing the client's diet plan, the nurse should include, yes, ladies and gentlemen, we look for a diet that is very rich in animal proteins, because that will be so important for pressure injury healing. Okay, so when you look at this one, we can have ground beef patties, okay, as our correct answer. So meat is an excellent source of complete protein, who, which this gland needs to repair the tissue breakdown caused by the pressure ulcers. A nursing assistant tells the nurse that a client with paraplegia has an area of skin breakdown on the left calf. When the nurse assesses the client, they are sitting on a cushion in a wheelchair and wearing a specialty boots. The nurse notes a circular wound 2 by 2 by 2 by 2 by 0.5 centimeters on the posterior aspect of the calf. What most likely caused the client's skin breakdown? Specialty boots. Great, thank you. D. So the area of the skin breakdown was most likely caused by the specialty boot, ordered to reduce pressure on the heels, rubbing against the skin. The community health nurse is working with a client who has limited mobility. Which intervention would the nurse implement for the primary prevention of skin breakdown? Instruction on the application of lotion. Yes, we don't want them dry. Assistant with the client in scheduling a visit to the healthcare provider. Okay. Educating of the client on turning frequently in bed if lying. Yes. Encouragement of the client to walk around the home 3 times a day. And care of stage 3 on the client's right heel. So the client needing primary prevention of skin breakdown will not have any skin breakdown at the present, but will need interventions to help this prevention. So encouraging the client with mobility, including turning the bed, ambulating in the house, will help prevent the pressure ulcers, okay, that normally leads to this skin breakdown. Having the client skin, having a dry skin is also a risk factor for skin breakdown. So helping educate the client application of lotion will help with this. While the client may need assistance with scheduling a visit to the healthcare provider, this is not a direct intervention to prevent skin breakdown. If the patient already has a skin breakdown, this will involve a tertiary prevention, so deterioration to a higher stage does not occur. Okay? A nurse is caring for an elderly client with a pressure ulcer on the sacrum. When teaching the client about dietary intake, which food should the nurse emphasize? We go for the complete protein, and that is lean meat and low fat, low fat milk. Okay? The nurse has been teaching a client about a high protein diet. The teaching is successful if the client identifies which one as a high protein. Animal protein, yes, baked beans, hamburger, and milk. Great. Thank you so much. When assessing a client who is incontinent for a risk for developing a pressure ulcer, the nurse should note which factor that can most alter tissue tolerance and lead to development of a pressure ulcer. Exposure to moist, yeah? Remember we had said that pressure ulcers result from pressure, friction, and shear and the skin microclimate, okay? So in this case, they were testing about microclimate, okay? Because evidence suggests that extremes of temperature and or humidity appear to increase the sensitivity of the skin to damaging effects of the pressure, okay, shear stress and friction. So excessive moisture is also known to make the skin more susceptible to pressure changes. The nurse has positioned the gland on the right side. You can see in my diagram here. Which areas would the nurse assess for pressure when repositioning 2 hours later? Auricle? Yes. Clavicle? Not really. The ankle? Yes. Greater trochanter? The heels? Great. So the nurse must assess the pressure points from the sideline every 2 hours. These include the auricle, the shoulders, the ribs, the greater trochanter, medial and lateral condyles, and the ankles. Structures to the midline, such as the coccyx and the heels, will not experience the pressure. Okay? The coccyx and the heels will not experience the pressure. So these are the areas you need to be aware of. Most hit areas: inner heels, heel, hip, lower back and buttocks, elbow, greater trochanter, shoulder, back of the head, and knees. Okay? Okay, thank you so much. We've come to the end of our topic. Please remember to subscribe so that we can be able to get more videos. Thank you so much.